So now we're going to talk about a 3D biopsy. So I've had all this experience with computer simulation based on my brachytherapy practice and development. And Dr. Crawford and his group at the University of Colorado have had a lot of experience with 3D modeling based on whole mount prostatectomy specimens. And so when I moved to Colorado in 2012, I sat down with Dr. Crawford and Dr. Lucia, a pathologist, who's going to be speaking tomorrow. He's got a very fascinating talk. He's going to be the first speaker tomorrow. You think that because of all this PSA we've had, when you look at whole mount sections of the prostate, the cancers have gotten smaller and smaller. But that may not be true. So be sure you're here for the first lecture tomorrow. So we sat down and we said, we got to figure out how we can get an answer to this problem. And the problem for us was being relatively sure that when you're dealing with a patient who you believe has Gleason 6 prostate cancer, he really does. There's nothing else there. So you can safely treat him like a patient who's presenting for a colonoscopy and you find a polyp and you say goodbye for 5 years. So that was goal one. Goal two was many patients should be candidates for focal therapy. But you can't do focal therapy, in my mind, if you're missing 30% of the lesions. Because what's the point? I was really taken aback a few years ago when the AUA was in New Orleans and the FDA had convened a panel on focal therapy, and we're discussing what criteria you would use to measure the success of focal therapy, because PSA is not obviously going to work very well. And Eric Klein from the Cleveland Clinic said, you know, I'll just freeze one lobe or treat one lobe, and 10 years later when that other cancer declares itself, I'll go after the other lobe. I thought that was the most, I have a lot of respect for Dr. Klein, but I thought that was the most ridiculous statement I ever heard. So to me, if you really want to do focal therapy, and I believe focal therapy is going to be the predominant way we treat prostate cancer in the future, you really need to have the information about where those cancers are that need to be treated, and you need to have a way to guide you with a high degree of accuracy to those sites so you can ablate them and only them and not half the prostate. So having those goals in mind is what spurred my interest in trying to develop technology. And this is not coming up with a needle or one thing or software. It's coming up with a whole package that can steer you to that direction. So I'm going to show about a 10 or 15 minute movie. Dr. Crawford was supposed to be here doing some of this, but Dr. Crawford got awarded an alumni award back at the University of Colorado, and they're giving him the award tonight. So he said, Neil, I'm not coming. I'm going to let you give it. So I said, okay, Dave, I'll film you. So I went to his office and I filmed him. So you'll see him talking, and then I'm going to show on the video some of the device that we developed, and Dr. Lucia is going to demonstrate it on a prostate cancer, prostate that was removed, and how the device works. That's about 10 or 15 minutes, and then I'm going to walk you through the software component of the 3D biopsy approach. Now, none of these devices are approved for clinical use. They're still in development. The software we have we call it a usability study, and that study is going at the University of Colorado. It's about to start at University of California, San Francisco, and in 3 centers in Europe. You'll see first case that we did with the software at the University of Colorado, and I'll walk you through how the software works. And I'm open to suggestions about, well, I don't like this, I don't like that, so we'll take some time to go through it. The whole thing will take more than 30 minutes. So if we could start the video, please, John.
Hi, this is E. David Crawford from the University of Colorado. Today, we are going to look at 2 cases. One is a mapping biopsy, and the second one is a targeted focal therapy. Several decades ago, we became interested in mapping biopsies and 3D reconstruction of the prostate. Why? Because when we do transrectal biopsies, these are basically random biopsies that sample less than 0.5% of the prostate. We literally make sort of life and death decisions on how patients are managed. And a lot of things have happened in the past couple decades. One is that we've learned that there's this overdiagnosis and overtreatment of prostate cancer primarily driven by PSA testing, but also because of the concern that even when someone has a low-grade cancer, like a Gleason 6 cancer, that it might be the person may be harboring a higher grade cancer, like a 7, 8, 9, or 10 cancer. And so over the years we've developed this technique, and it's based on the pioneering work of a lot of people, Winston Barzell and Nelson Stone and others, looking at these transperineal biopsies of the prostate. And we developed sort of a technique and a program for this, and it's evolved quite substantially over the past 5 or 6 years with better computer programs, with newer devices and ways to do biopsies. And so what we find out, and these patients are really going to illustrate this, is that if we take 100 patients that have, say, a Gleason 6, and 1 or 2 cores might be NCCN, very low or low-risk prostate cancer, and maybe even a 3, 4, 7, what we find out is that people feel, well, they're a great candidate for active surveillance. And we have things to help us determine if some people are candidates for active surveillance, but they're not perfect. And what we find out is when we do these mapping biopsies of the prostate, first of all, they're as accurate as taking the prostate out and looking at it under a microscope with the pathologist, even whole mouse. And we've done some 70 prostates that I've done radical prostatectomies on that have had we've looked at the results of the mapping biopsies and compared it to the whole mouse. And so what we find out basically is about 30% of people will harbor badness. In other words, they might look like they have a low-grade cancer and they have something that is even more substantial, Gleason 7s, 8s, 9s, and 10s. There's been an interest also recently in MRI interrogating the prostate. And there certainly are some advantages and disadvantages, but we have seen a number of patients, almost every couple of weeks we see a person like this has had multiple biopsies, or they've had one biopsy and a Gleason 6, they get an MRI, doesn't really show anything, we do mapping biopsies and we find a significant disease. So our first patient is going to be, and they're both in their 50s and they're relatively similar. One is a person that had mapping biopsies already and had a Gleason 3, 4, 7, a low PSA, and saw a lot of opinions and was told that he should have a definitive therapy such as a radical prostatectomy or radiation. He opted for these biopsies, and we'll show you what we found. One small area of a Gleason 3, 4, 7, right in the sort of mid-prostate, below the urethra, just above the prostatic capsule. And I would submit, I really don't think that guy needed to have a radical prostatectomy, and he's going to have targeted therapy. The second patient is very similar, except he hasn't had mapping biopsies. He's 57, has had an elevated PSA, I think about 6 or 7, underwent a biopsy and has a Gleason 3, 4. And he's been counseled as to having active surveillance. So again, these two cases really kind of reflect what we're seeing right now with a lot of men with prostate cancer, and look forward to sharing it with you.
Hello, I'm Dr. Nelson Stone. I am the CEO and founder of 3D Biopsy. I am also professor of urology and radiation oncology at the Icahn School of Medicine at Mount Sinai. We have developed a number of new instruments to improve the diagnosis of prostate cancer and other cancers. I'd like to describe for you our new 3D biopsy device. This is our variable actuator with its disposable needle attached. The variable actuator allows you to dial the distance of the specimen that you want to retrieve between 20 and 60 millimeters by turning this knob at the end of the biopsy device. That's going to change the position, I'm showing you here on my finger, the length of the shot. So it'll go from 60 millimeters to 20 millimeters by changing this position. So when the user, who could be a urologist or an interventional radiologist, is looking at the target, usually using ultrasound or MRI imaging, they're going to look at the target, a suspected tumor, see that its size may be 3 or 4 centimeters in length, dial this device to match the size of the image or the target, and they'll then go ahead and take a specimen. This is substantially different than other biopsy devices on the market because those are limited to specimens between 15 and 20 millimeters in length, whereas this device can take a specimen between 20 and 60 millimeters in length. You load the device by pulling back on the lever one time. That will expose the core bed. So I'm going to turn the device around and show you the needle core bed. You'll notice along the core bed, this is a 60 millimeter core bed, that there were ridges. I'm running my thumb over those ridges. The reason we put those ridges in the core bed is because we found when the cannula, this part, slides over the core bed, it tends to push the tissue down to the far end of the notch. That results in fragmentation and an incomplete specimen. In fact, the data shows when you're using a 20 millimeter biopsy gun, you typically only get 12 millimeters. So if you want to biopsy the entire length of the specimen, we need to get the entire length, not 60% of it. So by putting these ridges in, the cannula, when it cuts the tissue and pushes it into this notch, the ridges hold the tissue in place, allowing us to get upwards of 95% of the intended specimen. I also want to show you the tip. I'm putting my index finger here near the tip. This is a 4-point trocar tip. We also found when we were doing our experiments, the typical needle, biopsy needle, is a lancet tip. It's like the tip of a needle used to draw blood in a syringe. That causes the needle, when it's firing into the tissue, to deflect like this. Now, if you're trying to aim at a target deep in the body, needle deflection is a problem because the needle can then miss the target. This 4-point trocar system allows the needle to penetrate the body or the target tissue straight. In fact, our studies show that the deflection averages 0.1 millimeters when the needle is fired into the tissue. To fully load the device, you cock it one more time. That will retract the needle inside the cannula. You push the safety to release it, and then push the fire button, like that. This gun also has another feature that's of great interest to interventional radiologists, which is you can pull the lever back once and then fire it, and the needle doesn't move, just the cannula. Why is this important? This is important if an interventional radiologist is taking a biopsy near a critical structure. For example, a lung biopsy, and the mass may be near the mediastinum, and the interventional radiologist doesn't want to risk puncturing the large blood vessels in the mediastinum. So by using the gun this way, they can position the far end of the needle into the target, and it just advanced the cannula over the core bed without the tip of the needle moving, thus preventing any risk of injury to critical structures.
Hi, I'm Dr. Scott Lucia. I'm Vice Chair of Pathology at the University of Colorado and also a founder of 3D Biopsy. I'm holding in front of me the 3D Biopsy device. And from a pathologist's perspective, this is an important advance in how tissue is collected from the prostate. The reason for that is the variable length of tissue that this biopsy gun allows you to make allows us to be much more economical in terms of how we process the pathology tissue, and also gives us a straighter, more direct view of the prostate in a single axis, which, as we'll see, the old style gun does not allow us to do. When a prostate comes out of the body, it can vary in size from 3 to 6 centimeters in its largest dimension. And so when we process that, we know that the standard biopsy needle has only penetrated so far into the prostate. With this needle, penetration throughout the entire prostate can be accomplished, allowing us a more complete visualization of the prostate, and therefore better in terms of accuracy of finding cancer foci within it. So right here I have the prostate that has been removed from this gentleman, and it's just on top of a wax petri dish here for display. What we're going to do is take biopsy samples using both our guns, the 3D biopsy device and the standard barred needle. The 3D biopsy device has been cocked, ready to go. So we're going to take a biopsy through the longest section here. So what we want to do is measure what that displacement is going to be. It is just over 4 centimeters, 4.2, and we'll add 0.7 for the tip of the needle. So that's 4.9 centimeters. So I dial up my gun to 4.9 centimeters here. Now with that trajectory in mind, I place my needle as I'm going to be firing the tissue. Just going to secure the prostate while I do it. Normally this would be secured in the patient. You wouldn't have to do this. But for this demonstration, I'm making sure that the prostate doesn't move on me as I fire the gun. And I fire the gun, remove, and now we have to remove the tissue, which is now covered in the sleeve of the gun. To do that, I just cock the machine once. You can see the tissue is in here, and I'm measuring the amount of tissue that we are in there. From the placement of the tissue right there, we have 4.2 centimeters. So very precisely took out the entire core of 4.2 and is holding it in place in the gun. Another important aspect of the 3D biopsy system is the collection device that we have. Normally at this point, this tissue now has to be submitted to pathology in formalin. The standard way of doing this is either to take forceps and remove it, or a swab and remove the tissue and just put it in formalin. At that point, you've lost all orientation, and the tissue tends to fragment and fall apart in the tube when you do that. Our device allows this to be transferred as an entire core so that we can process it intact. By doing that, move over to the actuator device, a membrane that folds over the tissue. So we need to transfer the tissue, we place it on the pad, we turn the tissue to allow the placement of the material, and we pull it so that it strands off on the tissue. It can be slightly moved over just to keep it in line, but it keeps its position and length on the tissue here. This says 4.1, so I lost only 0.1 millimeters of compression by doing that. Then I can take the adhesive strip off. Once I've done that, I've opened up the adhesive strip. This membrane can be folded over the tissue to the adhesive strip. It is now holding the tissue in place along that pad. This can now be removed from the strip, holding the tissue in place, and placed into formalin. The membrane with the tissue in it floating in the formalin, and this is how it would be submitted to pathology, intact. This would fix in position here and can then be oriented with the sides of the tissue. This would be base, apex, for instance.
How do you fit that into a 3 centimeter processing cassette?
So once this tissue is fixed in this machine, in this device, it goes to pathology. It is directional, so that you ink the tip here as the basal portion of the biopsy. This would be the apical side, here the entrance side. So this fit into the prostate at that angle. So that can be differentially inked. Then the pathologist grossing team would take it. These are standard size is to cut, excuse me, I'm in the way, is to cut the tissue to be able to fit into the standard cassette. The standard cassette, as you can see here, has a bed in here that is 3 centimeters. So you don't want anything longer than 3 centimeters. Since our tissue is longer than 3 centimeters, we would have to divide that tissue. But we can differentially ink, put a pad of ink here to show the distal end, a pad of different color ink here to show the basal end, and you can simply, yeah, we can go ahead and do that to demonstrate. We have blue ink here in a standard blue ink distributor. A very small drop can be placed that will wick right into the tissue. The device actually uses it as a wick to do it. Here's the basal end, or the apical end, sorry. And we can do a different color ink, and it wicks into the tissue. Now you know it's like a game of dominoes, how the dots are opposite each other. So when I make this cut, those areas that are not inked, we know they can be aligned. And so we make the cut, one standard cut all the way across, dividing the tissue. Then the same cassette can be used. Can be picked up, put in the cassette, and the second one can be put right next to it because we know the inks hold the important spatial information. That is now ready for pathological processing in the standard of care.
Okay, now I'm going to show you the mapping software, and I've got no audio because I'm going to walk you through this. So this is made to be taken into the OR in the PC cart, plugged into the ultrasound machine, and you're ready to go. So you open the program with patient information, and you have to put in this information, the patient's age, his race, the PSA, did he have a prior biopsy, how many cores were positive, what was the Gleason score, is there a family history. Then you go on to the next page, which is calibration, so you can align the ultrasound machine grids to the software. You do this once, and then it's loaded, and then you don't need to do it again. This is very similar to brachytherapy software in terms of aligning the software grid to the grid on the ultrasound machine. So you have to align it in both an axial. You align the upper left and the lower right by simply just clicking here and clicking there, and then the virtual grid will appear over the grid of the ultrasound machine. Well, so this should take no more than a minute or two to do this setup. We made this software agnostic, so you can hook it up to any ultrasound machine you have in the OR or in the ambulatory surgery center. The only requirement is that you have the brachytherapy software and you have the biplanar electronic probe with the long pad in it. The software will also allow you to use MRI imaging if you prefer to do that. At the beginning of the case, it either says new or import, and there's a DICOM button up here. So if you've gotten an MRI and the radiologist has already segmented the prostate and identified the lesion, you can import that information, and then the segmentation is already done, but you will need to adjust the segmentation to the ultrasound image. So now we're adjusting the sagittal image of the prostate, and now we're acquiring images in Axial. So you can see the images are being acquired here into the software. It's very similar to brachytherapy acquisition. You're acquiring images at 5 millimeter intervals, and then you push the contour button, and you go ahead and do the contouring of the prostate and urethra. If you want, you can do the rectum and the seminal vesicles, but for this case, you could pick the color you want, mean, this is all very familiar to people who've done this with brachytherapy. I designed it so it was, I believe, very easy to use. This whole process of the contouring of the prostate shouldn't take more than 3 or 4 minutes. This allows you to create a 3D image of the prostate and urethra. It also allows the software to create the biopsy plan. So we're finishing up the contouring of the prostate. Now we're doing a live case here. So this is Dave Crawford's case, the first one he talked about at the beginning of the video. But the software is not approved for clinical use and has not been submitted to the FDA. So we're not allowed to use it clinically. So we're just basically paralleling the work that Dr. Crawford's doing in his biopsy. So he's doing his biopsies the regular way, taking biopsies every 5 millimeters through the template, and I'm copying the work he does. And it's going to be illustrative when you see what happens with the biopsies as he takes them and as the system records them. Conversely, when the system is fully in use, you're using the system to guide your biopsies. We can't do that here. So this comes up with a little window and allows you to pick the size of the needle. So that's a 17 gauge needle we're picking. You can choose how far to space the needles from the capsule and from the urethra, if you want to be right at them or a few millimeters away. You can choose to whether or not have the tip of the needle extend beyond the base of the prostate or the apex, keeping in mind the dead space of the needle is a portion from the tip to the beginning of the notch, and you don't sample any tissue. So if you want to be sampling tissue right up to the capsule, then you have to have the tip of the needle actually protrude a little bit from the capsule. So it generates a biopsy plan. Well, hard to see, but there are needle sites spaced 5 millimeters apart, and you can look at it in 3D. There's your biopsy plan at 5 millimeters. You can change the intensity of the color of the prostate or the urethra, or change the colors of anything. All pretty much straightforward. You get a bird's eye view. You can add needles, delete needles, till you're satisfied with the way the biopsy plan looks. The program will show you with a little red X where your largest gap is. So if you want to add another needle to the gap, you can add a needle there. Now, we're taking biopsies, and the blues are the places where the biopsies have been taken, and the greens is where we're working. And you can see, it's a little hard to see, but you can see that the spacing between the biopsy sites is no longer 5 millimeters because they're biopsying the prostate with ultrasound. They're not paying attention to actually what's being represented here. So you can see now the representation of the needle in sagittal, and you move the needle, the virtual needle, so it overlays the inserted needle both in the axial plane and in the sagittal plane. Again, that's very similar to how we do a seed implant. You put the needle in axial and you line it up in sagittal. So it's the same mechanism. The needles are designed to take a core to go with the gun I just showed you. So the core goes from the base of the prostate to the apex. But you can see the core bed here. See the notch there. You can adjust that. So if you want it to be longer, you can just increase the length or decrease the length of the core bed according to what you're seeing. You saw the needle only went halfway. So we'll have to take 2 biopsies there because you can't span the entire length of the prostate because the distance is longer than the 20 millimeter barred biopsy gun that he's using. If he was using the new gun, then he could dial that distance and take the biopsy all in one core. So you can see now, you can see better in blue how there are large gaps. Like for here, for example, there's no needles in there. And that's just a byproduct of the urologist taking biopsies, assuming that they're 5 millimeters apart, but in reality, because the prostate's moving, that they don't end up that way. So you really, just like you saw with the MRI guided systems, you need to have real-time guidance to be able to put those needles in the same place. So we're finished with it. The button says, "Are you done?" You click, it says it's done. Then you can look at your work. You can see how there are gaps here and here. As I said, because we're not using the software to guide the needles. We're just recording what was going on. So you can see in 3D afterwards the work you've done. If you want to go back and add another biopsy, for example here, you could always put another biopsy in there because that would be potentially an area that's unsampled that's fairly large. I said probably more than a centimeter apart. So then you're going to get on to the pathology phase. We're going to use the pathology device that Dr. Lucia showed you, and we're going to get a report back. And the report's going to say site 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, etc., because we start at the top and we work our way apart. So the software is going to require you, when you do the pathology component, to put in the pre-IPSS and pre-SHIM and post-SHIM scores, whether the patient had urinary retention, whether the patient had hematuria, whether he had a urinary tract infection, or whether or not he was hospitalized, and the treatment that's selected for this patient. And the reason we did that is because you'll be able to create reports afterwards, since you put the information in, to do statistical analysis. So then you click on the biopsy site, you're going to get the report back. It's going to say it was a Gleason 7. So there was a Gleason 7 lesion. It's going to say where did it start. You put it at the start point, and how long was the cancer, 15 millimeters, for example, at one site, and there was another site that was positive. And then you could look at the representation of those lesions, both in 2 dimensions and in 3 dimensions, with this report. So we forgot to fill something in, so it's going to not allow me to get the answers until I fill everything in. So let's go ahead and look at the 3D and 2D image. So there you see the blue needle and the yellow lesion around it. And so I put this little tool here on the lower right that allows me to extend the size of the lesion out to the next needle. Why did I do that? And here it is in Axial. So if you were going to do focal therapy, you would be able to export these axial images so they would be overlaid on top of the axial images of the treatment planning system, whether it's brachy or cryo or laser. This is very different, in my belief, to all the systems out there now that use software, because you can look at a representation of the lesion, but it's actually not overlaid in Axial on top of the lesion. I put the slide tool in here. So this is very important, because when you're taking, you can stop it now, John. When you're taking a biopsy that goes from the base to the apex, you have all the information of the length of that tumor in the z-axis, because you know where it starts and you know where it ends. You have no information about its extension in the x-axis or its extension in the y-axis, because you don't have any more information than what's outside that needle. This would be a 15 gauge needle, so that's about 1.5 millimeters wide. So how big is the cancer? This is a dilemma we have with MRI, because the MRI doesn't really accurately represent the extent of the lesion, and it could be within 1 millimeter of one edge, the MRI and the actual lesion, and it could be 2 centimeters difference in another edge. So it creates a dilemma how large to make the field of ablation if you're choosing focal therapy. So what I hypothesized was, you have those 3 lesions there. What we know is those needles around the lesions have no cancer, because we remove the tissue. So in theory, the lesion could be as large out to the next negative needle, because there's no needle, there's no cancer in the, if you're looking at the lower one, out to the next needle. So that slide tool allows you to grow the diameter in the X and Y plane out to the next negative needle. And then if you choose to do focal therapy in that patient, when you call up those images on your treatment planning system, you'll have a virtual representation of the theoretical size of the lesion. So that's the hypothesis anyway. We're going to demonstrate that in radical prostatectomy systems, radical prostatectomy specimens, but I believe that will give us really good actionable information on how large to grow our ablation zone up we're finding very small lesions. I'll talk to you tomorrow during the debate how small we can find and what the theory behind that is, but that's how we're going to hopefully introduce the system. Thank you.